Should I start, Dr. Smati?
Yes, ma'am.
Or will
Yes.
you be? Okay, fine. Uh, Good morning, everyone. We are now starting the multidisciplinary teams webinar in child and adolescent mental health. It's been a wonderful 6 months. We have had a lot of very fruitful discussions between all the teams. At the outset, I think I would like to thank, I think we will do a formal thank you at the end also, but I would definitely like to thank the Psychologists Collective, the Indian Association of Physiotherapists, the Women's Cell of Physiotherapists, the Indian Association Speech and Language Hearing Association, the All India Occupational Therapists Association, and of course, all the psychiatrists and members who have joined in out here. Today we'll have what we have been having earlier, case discussion with a panel discussion of from all the fields. Panel discussion on learnings, on the way ahead for all the team members and all the associations. And so each member from one association will be speaking. And the second part will wind up with that. So at the outset, the first case, this of course, what we have seen is, the degree of difficulty in the cases has increased. So this is a very difficult case which is being presented today. And we are really honored to have also a pediatrician here. It's psychological issues in a neurodevelopmental disorder. I'll be moderating the discussion, basically requesting the members to give their opinion. Please keep the discussion very case-based, and I invite Dr. Debushmita to start with the case presentation. You can introduce yourself briefly, Debushmita.
Yes, ma'am.
And continue.
So, I am Devasmita Gupte. I'm a clinical SLP. I'll be presenting this case. Thank you so much, especially the IPS West branch for supporting and supporting me so much to be able to come up and discuss this case. Very special thanks to the team over here, and obviously this audience is here on a Sunday morning. Thank you so much. So the case that we are going to be discussing today is that of a 7-year-old male child. The child today is 7. So we are going to be describing the entire timeline, hence the small visual of the timeline on top. It's a case of twin births with the boy weighing 1.2 kg at birth, the sister, the girl weighing 2. They had a short 2 kg. They had a short NICU stay for growth purposes like you have with twin preemies. No other significant postnatal injury or issues. There was a score of issues which were detected with the male child at that time. That is, undescended testes, there was no anal aperture, absent sacrococcygeal complex, and a mitral valve incompetency. There were a series of surgeries between 8 months to 2 years of age for the child, correcting for these three things: valve incompetency, the descending of the testes, as well as creating and maintaining the patency of the anal aperture. The family is a nuclear setup with both parents holding postgraduate degrees in a non-consanguineous marriage. Please, thank you. Next is the development between 2 to 4 years of age after the hospitalizations, the intense hospitalization, repeated hospitalizations and recovery was over. The OT and PT intervention mainly looked at the generalized hypotonia leading to delayed milestones. Still, the child was able to start independently walking between 18 to 20 months of age with good physio intervention that started then, and running and jumping by at around 3. And the OTPT intervention continues for the anti-gravity muscle strength, bowel incontinence, and fine motor skills. So bowel incontinence continues to be a problem even till date. We are going to take that up later. During that time, the speech and language intervention that I started off with looked at basic language and communication, for which both the parents and the maid, they were trained. Because of twins, they always had maids around, which looked at gestures, pointing, and starting off the child on the developmental arc of what they had done with the girl child, like show the toys, get the child to track the toys, grasp from one side, grasp from the opposite side, and things like that. So between 24 to 27 months, I could judge and get a fair idea that the child is definitely not neurodiverse. He's neurotypical. He's gaining milestones, does not have any savant skills or any splinter skills. So he started with pointing. No, sorry, please stay in the earlier one. Thank you. So he started with pointing and word formation in 3 months' time, that is by 27 months, attained phrases and sentences, what we call as SLPs, we call he was linguistically an adult by 4 years of age. He attained all language milestones, as well as I started off with few oral strength building exercises. So he never had any issues with chewing and swallowing, just required stuff to be softened little bit in dal, dahi and water. The mom never had to grind and was never on a liquid diet. Next, please. Thank you. So between 4 to 7 years of age, the speech intervention mainly looked at improving jaw strength. He always had good jaw mobility. I still had to work on a lot of jaw strength, very specifically for retaining articulatory position. So because of general hypotonia, he still has a little bit of unintelligible speech. And at that time, between at 4, he had a lot of phonological processes, also called as misarticulations, the lay term for it. So no tongue thrust, no underbite. So for improving oral muscular strength to hold articulatory positions, I had to double back and work on the chewing exercises. He really didn't require much chewing exercises. And I had to do this after the physiotherapist had worked on the rib cage and the intercostal muscles. If the physiotherapist in that session worked on the pelvic floor, the child would fatigue out and lose endurance while I was working with him. And the usual ones I use kinesthetic feedback with positioning, temperature, and other visual and auditory feedback. The end was he could chew much more fibrous things now very easily, not requiring any softening, and his speech started improving. The clarity and the articulation started improving. Next, please. So in the between the same time, 4 to 7 years of age, the other progress and developmental domains look something like this. So he started attending a regular mainstream school with his twin sister, presently in the second standard, a very intelligent and a curious child, very good at elocution, maths, world knowledge, can beat us in chess very easily. The challenges, what the issues look like, is that he consistently challenges authorities. So it could be not falling in line with consequences, not taking punishments, consistently challenging us as adults. Tell me what makes me an adult, and I'm going to do that, and I'm not going to listen to you. I'm giving you further examples. He still does not like to admit mistakes or apologize, to the extent that he will attempt physical harm and revenge if insisted. He has done this with a couple of friends, pouring something hot because that friend had done something undesirable to him, just like taking away toys, not returning toys, taking away colors. This actually meant harm. Lies in general. So even when we are working through the session, it is very difficult to understand whether a particular bullying incident, for example, has actually happened, or he's playing the victim card with me in the end to get something else out of me. Like I'll give you an example later. Threatens mom with suicidal tendency if she attempts to punish him for any type of inappropriate or incorrect behavior, like we deal with any of the neurotypical kid. I'm not going to talk to you for some time. Your TV rights are gone for the day. I'm not going to take you to the garden. So these are directly threatened with tendencies like, okay, so if I'm not there anymore, then will you look at me? Then will you talk to me? Things like that. Next slide, please. So he has been inappropriately touching his sister for the last 2 years, from the time he was 5 and asking her to be quiet about it. So from the time we were aware, all the therapists that we were working with, and we were aware, the first thing we suggested the parents is please don't bathe them together, don't clothe them together. That was done a long time back. But like I said, he's a very intelligent and a curious child. So separating them does not mean those private trustees to exist. He's even more frustrated that, it has been done. The sister will never rat him out. Very loyal, very protective of the brother, knowing, understanding his issues. This child has a very wide circle of friends. He likes his friends. He's very possessive about them and holds up an image of extreme good self-esteem. So the bowel incontinence hits very hard because he still has to wear a diaper in a second standard classroom. It's an international school, so the strength is very small. So it stinks up very badly. So it comes on his esteem that my friends are going to know that I'm going to have a weakness. So the inferiority possibly rises, the complex rises from there, and there are other related behaviors also. So just going to take 30 more seconds of your time. We are done. So when we work with him, working with him in general gets very difficult. So if I'm doing any articulatory exercises, I'm doing a reading exercise with him, there are going to be diversifications like, okay, so who is a family member versus who is a friend? So who do I the questions are not direct. Who do I start touching? So was your husband your friend or your family member first? When could you touch? And if I try getting him back on track, there are going to be several very subtle manipulative techniques, even in threatening me, basically. So there is no overriding this child. And one last comment that I would like to make: he's not a volatile, temperamental, or a violent child. He's not. He's very observant. He's very quiet, and he's very quietly persuasive about his ways. So thank you so much. Looking forward to the entire team's uh, inputs now. Thank you, ma'am. I'll be on mute.
Yeah, thank you, Dr. Debuchmita. Dr. Nishant, I know you have another meeting. So could you please go ahead, self-introduce, and please give your inputs for this case.
Yeah. Hello. Good morning, everyone. Myself, Dr. Nishant. I'm a pediatric neurologist at Rajkot, Gujarat. So can we go to the first slide, please? So neurologically, I would like to diagnose this case first. As we can see here, there are multiple problems, right? Starting from the birth. Child had undescended testes, no anal opening, and absent sacrococcygeal complex with mitral valve. So there is multi-system involvement, right? And child had initially global developmental delay to start with, motor as well as fine motor and speech, and predominantly hypotonia. So like every case, we try to reach a diagnosis. What is the lesion, where is the lesion, and why is the lesion, right? So what is the lesion? We have enumerate all these findings. So now why is the lesion and where is the lesion? For hypotonia, we can localize it to spinal cord because there is absent sacrococcygeal complex. So the spinal cord quality may be different, which may lead to hypotonia. It could be an LMN lesion or plus some sort of UMN lesion also. So that may have led to hypotonia during initial phase. And with physiotherapy, he has improved. Why physiotherapy is important? What if we don't do physiotherapy? So the answer is hypotonia may turn into hypertonia and giving rise to contractures. So better we start early rehabilitation in such cases. Other thing is no anal opening. So child has anorectal malformation also along with undescended testes. So he must have been operated initially. And as I guess in future, in further history, child is soiling and he is wearing diapers. So there are less sensation, I think, and that is the reason why he's soiling. So how do you connect the dots? So this seems to be a genetic etiology, and we generally commonly see as a vectoral association. This is a syndrome, vectoral syndrome, that leads to multiple problems, and it is a genetic condition. How do we diagnose it? We generally do exome sequencing, and we can come to a conclusion for parents why this has happened to child. And how does that happen in our rehabilitation? We can prognosticate on that basis, and future pregnancy, we can also plan accordingly. Right. So this is a vectoral association, and that has led to all these malformations. So vectoral is V for vertebral anomaly, A for anorectal, C for cardiac. So out of 6, 3 criteria are meeting here. So I think it is fitting into the diagnosis of vectoral association.
Okay, right. Do you have anything more to add, Dr. Nishant?
The child has already been on a rehabilitation program and he is doing fairly good, but
Okay.
right now seems to be developing a psychiatric diagnosis, and he must be receiving psychological rehabilitation
Yes.
as well.
Okay. Right. So then your impression is that obviously the vectoral diagnosis and exome sequencing that has to be done and genetic counseling for
Is
future
required.
pregnancies, that is something that the counseling that the parents need to have.
And
I
that
would go
also
on.
gives us the idea that whether it's a
Yes.
static condition or a progressive condition.
Okay.
So this seems to be a static condition. It is not going to progress in future.
Yes. Okay. So for the behavioral problems that have come up subsequently, I would like Dr. Vaidehi, who's a psychiatrist, to comment and give her, opinion about what can be done in terms of assessment and intervention. Dr. Vaidehi Arwari, please introduce yourself briefly and you can continue.
Good morning, everyone. I am Dr. Vaidehi Arwari. I'm currently working as senior resident in the Department of Psychiatry in Nair Hospital, where I did my fellowship of child and adolescent psychiatry. Can we go to the first? Okay, so the concerns, so psychiatric point of view that we see are the evolving conduct traits wherein the child is lying, is vindictive, violating sister's personal space, harming her in a way, threatening to harm if punished. So we see that he's nicely manipulative, and as we saw from Debasmita ma'am's presentation, that he manipulates in a way that the other person will be persuaded to follow his demands, and eventually he gets what he wants. Significant history that we've seen is that there has been a developmental delay where he is covered up with the delay with good consistent therapy, and he has shown good response to therapy. He had multiple surgeries at a very young age, and hence he's not achieved a bowel control, so he has to wear diapers even in the second grade. We see that he has a good almost above average intelligence for the current grade system. He's won Olympiads, he's developed an interest in chess, and he has a wide circle of friends. So in a way, we understand that intellectually he's developing well. Next slide, please. So my approach would be, first we need to have a good rapport with this child. We can start off understand that he's not going to be very open at the first get-go. So we develop rapport, a therapeutic alliance with exercises, with puzzles, crosswords, maybe avoid chess. At the beginning, it is his arena, so let's not be more threatening to him in his arena. Non-threatening exercises. Interviewing parents. Here now it's important to understand what have been the parenting styles, whether it's too permissive, is it too authoritative, if it is consistent across the parents, if is there any neglectful parenting on either of the parents' part, what is happening exactly between the parents and how their interaction with the child takes place at home. So understanding this family dynamics, that who is the main point person in the family who takes the decisions, who's the main disciplinarian where the kids are concerned. Child's relationship with sister, like previous, like before he developed these traits, how it was, currently how it is, the parents' relationship with sister. Now, how do they discipline each of the child, whether it is different, whether it is similar across both children? Has the children, sister been taught to be more permissive and be more careful and protective of the child, since he's been having a lot of issues since a very early age, going to therapies, going to surgeries? Has she developed a parent role towards this child, and hence because she herself is a 7-year-old, she's not going to understand what is right, what is wrong, and where to set the boundaries. But the protectiveness, the maternal instinct is there. We need to absolutely first look for abuse. Now, this can be any abuse, emotional, whether it is happening in the school, whether there is any bullying at any level, whether it is happening in any other setting, whether the family talks that the child hears, the extended family, what his interactions have been with them. Is there any physical abuse in terms of punishment, whether in school or at home? Any sexual abuse in any kind of setting. Understanding that this the reason that the child is going for more sexual exploration with his sister, if that is just a developmental exploration or something that he's mimicking. These things need to be looked out and ruled out at first. We should also be very considerate of the emotional issues, because the child is definitely having self-esteem issues. He has a good intelligence. He understands he's not equivalent to his peers, because he has to still wear diapers when they stopped wearing diapers. So has that caused how much of emotional issues? What is the severity? He definitely apparently mentioned a self-esteem issue, but how much is it warranting a if what behaviors are there, is it an acting out of one of the underlying emotional issues? When he threatens to attempt suicide, whether he has seen this in front of him, whether it has happened in the family, is there a family history of suicide, is there an actual tendency, planning, and some secret attempt even so. He may be just threatening, but how much seriousness, what is the gravity of this threats is something that needs to be assessed and ruled out before we go towards the actual diagnosis. Other neurodevelopmental disorders. So with conduct, we see that comorbidity is a rule. So first, we need to rule out if there is any other neurodevelopmental psycho comorbidities like ADHD. If there are some subtle autistic traits which we've not seen so far, but it will be wise to rule that out. And also take the school teachers' account. How is the classroom behavior, academic wise, the peer relations, in play, how is he? So understanding all the settings. Also, we now are going to know from each and every therapist. So having a good liaison with each and every therapist, how is he in different therapy sessions, what triggers him, what ticks him is important too. Can we go to the next slide? Assessment wise, projective tests is something we would like to do. The child apperception test, which would give us an idea about the child's self-image as well as the family dynamics. If the child is not able to attempt, then a draw a person test. So understanding the child's self-image is much more important for us to go ahead with all our therapies and approaches. IQ test to get an idea, to get an actual number on the IQ. Observing this child in different therapy sessions, how is he interacting with the therapist? Because an authoritative figure is there. So how is he interacting with each therapist, and who is if a therapist is lenient, then how is he responding? If they are a little strict, then how is he responding? Observing so the family dynamics, observing in a uncontrolled environment wherein we can go for the one-way mirror approach, where there is a sofa, you just ask the family to wait there for you for some time, and there is a mirror that cannot be seen from the side of the family. So the one-way mirror is on the therapist side, so you can see through what is happening in that room. So you observe the family, their dynamics, without them knowing that there is someone to observe. So how is the child without a third party? With the parents, with the sister, what is the parents' interaction? How are they disciplining each of the children, or if they are interacting, if there is any parent seeking, caregiver attention seeking, what is happening exactly? Because the settings matter. In different settings, how is the child, how is he reacting, and how are the parents reacting? Because there will be one thing they say and one thing they do that we need to always check and rule out. So understanding the sibling relationship and parent-child interaction, we give them a scale for ADHD, the corners parent and teacher rating scales. And here we get an active input of the teacher's understanding and observation. Also, if the child has ADHD or his behaviors that she notes down usually on the rating scale, gives us a good idea to rule out ADHD. We can do a conduct disorder rating scale, which is a clinician, parent, and teacher rated scale. So with the history that I have for now, we can give the differentials of conduct disorder. And ADHD, though the child is performing well and it's not seen on history, but then if it is an inattention predominant with impulsivity, is something we need to rule out. If this is just an adjustment reaction, or if it is acting out of some underlying mood disorder, is something we need to really take care of. Next slide, please. So management wise, first and foremost, building a good therapeutic alliance with not just the child, the entire family one-on-one is very important, because we need the entire family in on this. So no blame game, whether the parents, we have to teach each of them. It's not just because of you, because of me. The parents are not to blame each other. They're not to blame the child also working in front of him. So it has to have be a good rapport with each member, so that we can work well with them. Parent management training is at the heart of it, because what is happening at home, how are they training, how are they teaching, what is good, bad is important. So there should also be a consistency. So between parent to parent, the mother and father need to be on the same page, consistently give the same kind of treatment for behaviors that are decided. How they are supposed to do contingency management at home is need to be taught to them. Positive, negative reinforcement and how to apply them needs to be taught to them. Individual therapy sessions with the child, wherein you and make the child understand limit setting, boundaries, sex education through charts, models, whichever. Make the child understand good touch, bad touch, that you are not supposed to touch someone and someone else is not supposed to touch you. It's a bad thing and you need to inform an adult, your parents most likely. This is very important to make even the sister understand, not just the child. What we can do for his impulsivity and a little aggression is low dose risperidone. We can start off with 0.25 milligram and then upright it with 0.25 milligram every week, seeing how the child responds to 2 milligram max in divided doses. We address the child's self-esteem issues first, and understanding of his image, continence issues, and address them. Develop his strengths like chess, Olympiad, so that more time is spent constructively instead of whatever else he is seeking out maybe attention to. Treat the comorbidities. If we find ADHD, we give him stimulants like methylphenidate. If there is any mood fluctuations, there are anger outbursts, and it's a fluctuating mood, we look for mood stabilizers, which can even be given for his aggression. Close weekly follow-up so that there is consistency, because otherwise the child, your alliance, the rapport and all will be shaken if you keep a very spaced out follow-ups. And checking his improvement in all settings, not just in therapy sessions, not just at home, even school and other settings where there are problems happening. I am majorly done with my presentation. Anyone?
Thank you, Dehi. That was very succinct. Before I round up, I've had a little few questions both to Dr. Nishant and you. I think I understood that, one is from the assessment side, from the pediatric neurologist assessment side, and from the psychiatrist side in terms of what has to be done now. Just a couple of questions, because I know Dr. Nishant probably has to leave now. What about prognostication in terms of this child from both the psychiatrists? Because, for a child like this, the parents will usually ask, like, we have a finite life. So in future, what is the, future lifespan of the child? And in terms of, what are the steps to be taken care of when the child becomes older, as in an older, adult, and comes to adulthood also, in terms of care. Any quick answers to that before we go to Poonam for her psychological inputs, intervention inputs?
Yeah, so
Yeah.
neurologically, child has started walking. So motor-wise, he is absolutely okay. And he is doing good at school academically also, though we need to get IQ done because this is a syndrome. We always get IQ done in syndromic child because they may face academic difficulties in futures. So neurologically, I think he's going to do fine, even if it is a vectoral syndrome. But the issue is he has anorectal malformation, which has been operated, but they may have less sensation neurogenic issue with their rectum. So it may lead to a soiling for a longer period. Otherwise, neurologically, he is going to be fine. He can lead independent, successful life.
Okay. Thank you. Anything else you want to add, Dr. Vaidhi,
I
in
would
terms
like
of,
to
when
add
the
that
child grows up?
for us also, so the early onset that we consider in a conduct disorder, so before 10 years of age, is usually considered as a bad prognosis. But more than that, it is the level of aggression and outbursts that are considered as a prognostic factor than the age of onset, is what has been seen in the studies. So accordingly, the parents are quite involved. They've been consistently doing therapies from a very young age, so that good family support will point towards a better prognosis. So we have to watch for any antisocial personality disorder development, and hence educate the family in you have to give him a warm home environment. The environment matters, the nature and nurture. So the nurture here plays an active role. So how the child is going to evolve depends
Fine.
on
Thank you.
activity.
Now we'll go on for the psychologist's intervention. Ms. Poonam Agarwal, please briefly introduce yourself and you can start.
Good morning, everyone.
Poonam?
Am I audible? Am I audible? Hello?
Yes, ma'am,
Yes,
you are
yes.
audible.
Yes,
You're
yes.
audible.
So, as you can see, I have been working in this field for the last 24 years, and my forte has been completely into assessments and completely into all kind of assessments. And today I am here with this podium in terms of talking about it. So, I'd like to talk about it. The next slide, wherein this is the case when my area would be completely focusing on the assessment. Till now, we've already spoken about the case history and other things, and the child has undergone therapy. So, first and foremost, when a client comes to you in terms of such kind of a case with complex difficulty, it's very important that we also take the input from the parent that whether there has been any kind of assessments done earlier, which is the most important thing, because since we know it's a therapy which has been started, so any kind of assessment done at the age of 3, 4, 5, whatever that is there. So that's the first most important thing, because we already have a brief case history about the child. Second, there are list of assessments that needs to be done, but it is not necessary that you need to do all the moment the child comes to you, because we always has this thing, this, if something is already done 6 months prior or 4 months prior, please do not repeat it. That's the most important thing. So cognitive, now we've been hearing about IQ, and IQ. We need to also understand that there are other comorbid conditions. So why IQ is important and how do we correlate IQ with the other conditions? So as we all know that high IQ with high ADHD, high IQ with autism. So there are different computations and combinations that are involved. So each test has to be understood individually at the same time in terms of combinations. So first is the IQ test. If you've already done it, so we don't repeat it. We wait for another 6 to 8 months and then we repeat it. Then we also have something what is known as VAB, that's the Vinland's Adaptive Behavior Scale. Why it is important? Because the child is very small. The child is also undergoing speech, OT, and PT. And with this, we will get an idea as a psychologist that what has been the developmental pattern. So that is very important. This is something which can be used as a pre and a post, because as and when the child is coming to you for counseling, he's there and other therapies are on. You do get feedbacks from the therapist as to how the child is performing, but these tests really help us to measure the pre and the post. As earlier, speakers have already spoken about ruling about neurodevelopmental. So we do talk about ADHD, autism, other differential diagnoses like conduct disorder, oppositional defiance disorder. So these things also have to be ruled out. One of the most important thing that we all need to understand in this particular case is that we've been talking about high, above average, very good in elocution, very good in chess, these kind of things. So there's very, very likely that there will be a lot of emotional issues coming up, which we can already see, right? So there are various tests that needs to be done, because sometimes during the therapy, during the counseling sessions, the clients don't talk. The child does not talk to you. He will not talk about it because he's got lying, manipulative, and other kind of tendencies. So as we know, there are a lot of projective techniques that can be done, especially in terms of checking with any kind of physical abuse, sexual abuse. So that you do have tests which are HTPs and CAT that is there, which gives you an information. HTP is one of the very good tests, which really gives you the family dynamics, as well as if there is sexual abuse that has happened, you will get to know about it. So that's the most important thing. So HTP, we're not supposed to miss it out. CAT is something which also gives us very good information. And if there is anything that we are doing during the play therapy or other things, which I've talked about in my intervention. Most important is the observation input, because we've done the assessment. The assessment takes like whatever 3-4 sessions that needs to be done. An assessment has to be done once. You can't keep repeating it at regular intervals. You have to give a time of 1 year span because the therapy requires that much time. So minimum 6 months, maximum 1 year. And that's how you repeat your assessments if required. Otherwise, you wait till the therapy inputs come to you. Most important is the trio observation inputs is very important. The naturalistic observation, because we get observations from the therapists, the parents, the caretakers. We've missed out the maid because there has been a caretaker. Parents have been working. Both the parents have been working. So we really don't know what has been the teaching, learning, or the inputs coming in from the maid or the caretaker, or if the child is in the creche or daycare center. So these things also have to be tapped up as to what he's learning, what has been happening about all these things. The observation input, if possible, needs to be done on regular intervals. Some kind of checklist can be given to the parents and everybody so that you get a more objective input, because subjective inputs do come in, but again, objective inputs at regular intervals are required. Reviewing in terms of therapies, because if the assessment, since the therapy is already on, right? So there has been some assessments in terms of the therapy part, that is PT, OT, and ST. So if you can get inputs as to what was the assessment pre and prior, because that gives you a very good input in terms of the improvement or the graph that is happening overall and in terms of specific areas. Because when you're doing BABS, it then cross-checks that which area is developing and which area is not developing. So that's very important. So assessment looks very, IQ kar lijiye or developmental ADHD, you need to do this. But at the same time, you have to understand that how important is the assessment factor. Individual scores need to be considered. Like, for example, IQ, and in combination, how it's working with an high IQ with a conduct disorder. So that helps you with your management strategy. Next. Now, in terms of intervention, first and foremost, I would like to say that as a therapist, when we start, there are two things that we need to keep in mind and also help the parent constantly inculcating in them is that, one, accept your child condition and accept the way he is. Because it's very, very difficult, because one child is absolutely growing as per the age and the other second child has lot of difficulty, right? So it's very, very important. The parent might have said, humne suna hai, I've heard it, but you have to constantly keep repeating the same thing so that it imbibes into him, because once it is imbibing in them, that gets transferred to the child. It's very important. We say, na, if I have accepted it, my child will also accept. If I have not accepted my child's disability, it's very difficult for me to explain it to my child. So identifying the strengths and weaknesses, you have to identify the strengths and weaknesses, verbal, physical, and non-verbal. Because we know motor is good, speech has been good, but there has been difficulty physically because of the hypotonia. So encourage the activities accordingly. As of now, the child is involving into only solo activities like chess, elocution. These are solo activities. What about peer relationships? So there has to be some activity which will involve at least 2 to 3 people. I'm not saying a larger group because the child is small, but slowly and gradually you have to encourage that, because that will help in terms of understanding of fear of success and fear of failure. That's very important, because chess, again, you get aggressive. Oh, I cannot fail, because if you have a high IQ with other concerns. Emotional behavioral difficulties, you need to identify separately at home, school, and therapy. Because what we get is the general information. But what specifically, because it's a manipulative, lying kind of behavior, so we have to differentiate. Accordingly, the therapy will then help them. These are some of the therapies that can be worked. All have to be worked, but at different stages, depending on what is required first. So starting out with your cognitive, because if the child has high IQ, then definitely CBT and REBT would work, because REBT with children really works because it's a combination with art-based and play therapy. So we need to really look at that, because the child is not vocal in terms of expressing the emotional behavioral difficulty. It will show up in the play therapy. parent and family counseling is important because in this, you don't just need to not focus on the father, mother, but also the caretaker. Caretaker has to be a part of it because she is going to be there for the larger period of time. Support systems, as I had mentioned, behavior modification, plan as whereas management program. You need to plan something, you need to monitor it, and then see the progress, because that it will keep helping you to keep changing it. And the social skill training program, which will be done in school therapy as well as with the therapist, that's a psychologist working, focusing more on social interaction and peer relationship. It's too early, I would say, because 7 hai, you need to give some time, space, try and understand what the child is also going through. Developmental education program to both sibling and well as parents. It's not just teaching the child what to touch and what not to touch, what is good touch, what is bad touch, but also to the parent that this is an age where you have to teach. And similarly, similar page has to be seen that, okay, if this is happening in the school, what is it that the teacher is giving the input as well? You know, sometimes teachers don't talk about it. They don't want to talk about it. So you need to get an input. So that is where we are saying that coordination with the trio is important. Next. Now, we all talk about parents, and that's the takeaway, is that make it a habit, it will work. You know, we always say therapy chal rahi hai. Only during the therapy you need to have positive attention or positive reinforcements. No, as parents, as therapists, as caretakers, we always have to keep in mind that yes, it has to be made it a habit, because this is a child who will require long-term intervention program, a really, really long-term intervention program. I know it's not easy because the frustration level, we feel it's not working, so our morale goes down. But as therapists, as parents, constantly we have to tell them you have to make it a habit, not only just for one child, because it's difficult for both the child. In order to have a conducive environment at home, these are some of the things that can be done, especially in terms of being honest, building self-esteem, constantly tapping on sleep and eating habits, screen time, which is important, which was seen that yes, the child is showing some kind of excessive screen time, which is showing up because it is like a substitution. Because I don't want to be social. I finished with my social, play activity like chess, elocution. But what next? Because I don't want to get into peers, so I'm getting into, screen time. And how to monitor the screen time, it's again very important. Why I have highlighted 3 words in the yellow is because our focus when it comes to difficult child is only more on that. Using harsh behavior, anger and insult, comparing kids. So these are some of the things which is a major things. We have to understand that we need to focus more on the positives and less on the negatives. The more you make it a habit of your positives, the negatives will automatically start reducing, because the more you're encouraging, the discouraging part which the child is getting, maybe the parents are not doing it because they have less time with the child, but how are they using the time? How is the maid using the time? These are some of the things that needs to be tapped and understood. Next. Now, since we have a bigger challenge, which is in school, because he's in 2nd standard, and we have a lot of bigger challenge because now the child is going to the school. So with the school, there are 3 things which needs to be understood as well as tapped with the class teacher.
Can I just request you to wind up quickly? We have 3 more speakers after you.
Just the last slide, ma'am, in 2 words,
Yes,
sentences.
sure. Thank
So
you.
3 things. 1, with the class teacher, is the classroom rule. Teaching style and learning style has to be understood, and the classroom management plan. So these are the 3 things which the therapist and the parent has to correlate with the class teacher. Thank you so much.
Thank you. Thank you very much, ma'am. And that was very wonderful that you spoke about the long-term, support that would be required, the parental support, and of course, addressing the other child too. Thank you very much. Now we go to Dr. Sushant Saran, who's an autist. Kindly introduce yourself and talk about your management plan for this child. Go ahead, Dr. Sushant.
Thank you, madam. Thank you, everyone. Good morning, everyone. I'm Dr. Sushant Sarang. I'm an associate professor at KM Hospital. I'm an occupational therapist and have been in the field for quite some time. Can you go to the next slide? When an occupational therapist sees any particular child or an adult, we primarily focus on 5 domains. So, occupations, client factors, context, patterns, and performance skills. So, primarily, what an occupational therapist does is he views the person as an occupational being. That means occupation or whatever activity the person does throughout the day, throughout his lifespan, is very important. Now, as far as the child is concerned here, HK, we would assess and intervene the child for these 5 domains. So, occupations are activities of daily living, instrumental activities of daily living, his academics, play, leisure, sleep, etc. Client factors are what are the factors which would be needed in the child, what are the sensory motor factors, what are the cognitive factors, psychosocial factors which are needed for the child to perform any activity. Context can again be divided into person context and environment context. Person context is whether the person in consideration is a child, adult, boy, girl, etc. Environment again, what type of parents he has, what type of family he has, what is the background of the child, etc. Where does he stay? Whether he stays in a slum, whether he stays in a building, whether he comes from a affluent background. So all this context also matters. Again, performance patterns, we try to find out what is the role that the child plays and it is important for him. Now in this particular child's case, the role of a student, the role of a brother, the role of a friend and a son, all these roles have been affected. We also need to take into consideration what is the routine that the child has. Then next is performance skills. We do what is called an analysis of occupational performance. That means we pick up those activities which the child has difficulty with. In his case, I think he may also be having difficulties with handwriting, but that's just an example. We would actually ask him to write and try to find out what are the motor skills, what are the process skills, and what are the social interaction skills that are inhibiting this child from performing to his optimum level. We would be using standardized and non-standardized assessment scales for all of these 5 domains. Like for the occupations, we may use assessment of motor and process skills. For client factors, of course, there are various skills like sensory integration, etc. Performance patterns, we would ask the parent to give his entire routine right from the time he wakes up to the time he sleeps. And performance skills is assessed by the therapist by doing analysis of occupational performance. So these are a few of the examples like sensory profile, child occupational self-assessment scale, etc. Now this particular scale, COSA, child assessment of child occupational self-assessment, is a scale which talks about how competent the child feels in performing certain activities and how much value he gives to it. Next. So I have put HKs, I have made an occupational profile for HK. So the inhibiting engagement factors, client factors are as given here. So he's got gross and fine motor difficulties, hypotonia, etc. As far as our topic today is concerned, he has defined behavior, does not like to admit. So all these would be inhibiting engagement, but we also take into consideration what are the supporting engagement. Next. So these are the occupations which are primarily affected according to what I have understood of the case. And again, the supporting engagement. Context, performance patterns, so routine details are not available. And performance skills, we would actually analyze the child by asking him to do certain occupations that are important to him. Next. So this would be the probable problem checklist. So the child has difficulties with engaging in the following activities: ADL, that is toilet activity, outdoor play and sports, I think due to his hypotonia and due to his developmental delay, the child would probably have difficulties in engaging in outdoor activities. Probably that is the reason why he has developed his indoor activity, that is chess as well. Social activities, again, this could be due to his inadequate social skills and use of diaper. Academic activities, I think he may have difficulties with writing, but that needs to be assessed. Next. So then further, there is lack of mastery in certain age-appropriate activities, speech and language impairment, feeling of inadequacy, emotional dysregulation, limited repertoire of socially acceptable behavior, parents' understanding of the behavioral approach. We'll have to check out if that is an issue. And then parent and teachers' understanding of the interplay of person, environment, and occupation. So in this case, what we will do is we may use the PEO model, that is person, environment, and occupation. Now, the child would perform to his optimum level only when there is an overlap of the person capacities or his abilities, the environment, his school or at home, and the occupation, maybe any activity that he is doing. Uh, if there is an overlap of this, only then there would be good fit and there would be better occupational performance. Next. So, according to our analysis, the undesired behavior displayed by HK appears to be secondary to his feelings of inadequacy, which in turn stems from his gross and fine motor deficits, impairment in speech and language, lack of assertiveness skills, and use of diaper for bowel continence. Now, due to his physical condition, HK had difficulties experiencing normal milestones, age appropriate activity engagement, and social interaction during his development. Parents may have been more lenient due to his physical condition. Because of this, HK is exhibiting inadequate occupational performance in certain activities expected at his age. Next. So this would be our intervention. We would primarily focus on the occupations and activities. That is, activity prescription is a very important aspect of occupational therapy. So these would be prescribed to improve his competence in age appropriate engagement. Activities would be chosen taking into consideration his abilities, interests, and relevance, and what he values most. These activities are gradually graded to offer increasing complexity. HK would be offered the just right challenge, and his inner drive would be tapped rather than forcing him to do certain activities. Next, therapeutic use of self would include, giving him respect, because this is an intelligent child. So we would need to give him respect. We cannot treat him like a child. We'll have to balance it out. Okay. Then of course we'll have to work on all the sensory, neuromuscular, skeletal, and other concerns that he has. Emotional regulation is addressed through various strategies. Environmental modification at home and at school needs to be done. Next. So social skills training and conflict resolution has to be planned for him. The sister can be involved in these activities as well. Teach about acceptance of use of diaper. Maybe we can give him an example of how even an Iron Man needs a suit to protect him. So maybe some acceptance in that form can be started. Educate about good touch, bad touch, and respecting other person's body. Provide alternatives to disruptive behavior and positively reinforce the acceptable behavior. Teach him acceptable ways of expressing disagreement and anger. And educate parents and teachers about the interaction of person, environment, and occupation for a good fit in his occupational performance. Yeah.
Yeah,
Yeah.
thank you.
Was it.
Thank you, Dr. Shashank. We'll quickly go to Dr. Archana. Can you come in? Yeah, briefly introduce yourself and you can go ahead.
Good morning. Am I audible?
Yes, you are.
Yes, I'm additional professor in physiotherapy. Can we please go to the next slide? Thank you, Psychiatry Association, for conducting such a comprehensive program and inviting me. So, going to this particular case where HK has certain motor impairments, very few, but yes, he has few which we have to be taken care of so that further morbidities are avoided. So, considering his general impairments, hypotonia is the first one. Can we go to the next slide? Yeah, so for hypotonia, we'll be assessing him. And because he's otherwise very active child, we would assess his posture for static as well as dynamic posture. So the static posture, basically, I would like to highlight whether the child want to assess basically whether sits in a W sitting position still at home. What is his chair looking like? Where does he sit usually? Then what is his static posture when he's doing bowel activities? Even that would be important for us to know. Along with hypotonia, which what comes is joint laxity. So does the child have laxity, and what is the grade of that laxity is definitely important for us. Then if it is lax, then we will have to plan our strategies to prevent any joint compression and further pain. So to treat hypotonia, we would be doing a lot of joint loading with the proper alignment in various functions that he's doing, whether it is a play activity, whether it is his studies, whether his school activity. The alignment has to be definitely taken care of. Because it is hypotonia, we'll be definitely looking for strengthening of his anti-gravity muscles, ankle joint mobility along, and the strength for all the joints that are concerned, right from trunk, hips, knees, ankles. So for functional integration, again, the various functions that a child is performing, the hypotonia, how it is impacting those functions is very important for us to know. And then the remedial factors have to be taken into consideration. Next slide, please. For balance, we as of now there is no impairment per se of balance, but yes, the case says that balance training is happening, and because he's having hypotonia, we don't know how it progresses. But sir said some time back that it seems to be a static one, but we never know. As a child is growing, then maybe some balance issues also might come in. So how do we assess? Is one few of the tests which we usually follow is the PBS, one leg standing time, sway analysis, and several other ones. So once the balance assessments are done, we know what are the limits for his stability. We would go for various strategies. Please go to the previous slide. Yeah. So hydrotherapy is one of the important therapy sessions which we look forward for children with hypotonia per se, where their hypotonia and the multisensorial integration can be brought about better into the water. It may not be always swimming, but it could be certain basic activities in the water, where his trunk, till the trunk level, he is immersed in water. Second strategy, which I would like to highlight, is visual occlusion treatment, where the eyes would be shielded and he would be in a secure place, and various balance treatments would be performed. Next strategy would be yoga, which where we would be saying emphasizing on various flexibilities, especially of his hip, knee, ankle, to take care of the balance strategies which we want to train the child for. So yoga would also help in various spiritual and meditative aspects, which are also required in children. Strengthening, as I mentioned, trunk, lower limb, and the joints of all these areas would be taken into consideration. So for strengthening, we would definitely think of the therabands, weight cuffs, and water, if possible. So fun activities which would help in balance and strengthening both would be skateboarding. Dance therapy can be definitely a very good family routine, which can be done maybe once in a week or twice in a week, everybody together, in a with a proper ambience. Next thing which we always do in our department are the brain gym activities, where it helps balance, helps strengthening, helps body image, all in one go. Next slide, please. For bowel, we know that the child is having good bladder control, but not bowel control. So he had a absent anus. So what has been done surgically is not been mentioned there, but we would definitely like to know what is his pelvic floor muscle strength, what are the remedial surgeries that have been done over there. That is not mentioned, but we would like to go into that detail to find out what best can be done for him. So what we've tried recently in a child with myelomeningocele and bowel issues was sensory re-education, and the parents said after around 8 to 12 weeks, there was certain improvement in the behavior as far as bowel training was concerned. So the next would be pelvic floor strengthening. Potty training, again, here what I mean is that whatever the toilet seat is, whether the child is sitting on that, what is the posture, whether he's liking the feel of that particular toilet seat, whether it is a Indian way, whether it is a Western commode, we have to find out what I would definitely suggest more of Indian type of squat sitting, which would be better, but we don't know what is the environmental thing happening at home. So again, for bowel training, the therapist would be trying, it is a team approach. The urologist, the parents, the maid, everybody has to be there into that particular training. Abdominal massage, myofascial release, both help in avoiding constipation and preventing the child from going into painful image of that particular function. Next slide, please. Okay, so the overall physiotherapy goals are the parental motivation. Even the parents, even if they are working full time, they still have a lot of psychological impact about their child's routine and their the future of the child. So we need to motivate the parents, saying that okay, we are going slowly ahead in the child's manner. So the family has to be having routines. So the parents have to provide that particular boy and the girl, both of them, about better quality time in form of play, in form of certain routine, making the child sleep at a particular time, how the child will be put off to sleep by doing some story reading or some discussion or something to do with the day-to-day course that the child has gone through. So that routine, I feel it is very important, and the parents give quality time to the child at least at a particular time in the end of the day. So the exercise routines also has to be a family activity. Parents can go in with the child for dance therapy. They can go for hikes, whatever the child feels like. The child's intention is whatever the child likes to do. So that can be a fun and engaging activity where the child's strength, stability, as well as the motor skills can be emphasized. Bonding has to be very good. The child also should feel very good about the exercise thing that is happening with the therapist. So whether it is stability, mobility, fun, games, whatever it is, the narrative the child portrays about exercise also has to be very good over a period of time. So that is what I would like to highlight about HK. Thank you very much.
Thank you, Dr. Archana. And we go to the final panelists, and we'll take a couple of questions. And yeah, Ms. Sheetal, please briefly introduce yourself. And yeah, thank you. And I would just request the speakers to put your videos on.
Ma'am, I'm down with cold, so
Okay,
I would just
fine,
like to
no
really
problem.
speak. So
Sure.
I'm a clinical psychologist and a special educator. I've been working with the Nair Hospital LD Clinic. So I'm being a part with Alka ma'am and Swati and all of us. So my inputs are basically whatever I've heard since we started the discussion. The child ideally does not have any academic concerns, is what I've understood. Okay, but for example, if I need to understand in case he's got any issues, first of all, I will not be using any standard tools. I would use something called as the teacher made test, the TMAs. Okay. So TMAs are basically done with a grade level assessment of the child. So the grade level syllabus that he's doing. Secondly, the child right now is in the second standard. So most of the times, whatever in the school would be happening more of like an objective, like, one-line answers, matched column. He would not be expected to write a little longer answers or things like that. It would be oral and the written part together. So probably right now, currently the child would not be having issues as such. But there's a possibility that as the standards go higher, if he's having difficulties, if I do a TMA, I would be able to understand the areas of concern. According to me, what I understand, because the IQ is quite good, he might be good with the reading and the comprehension. Issues majorly could be in the written areas because of his physical limitations also. So probably once I do the TMA, I can formulate an IEP, the individual education program, and depending on that, we would go ahead and give him certain uh, activities to do. For example, prerequisite skills of writing. So a little bit of like pattern drawing or matching the columns or things like that, and see whether he's got issues with the cursive writing. Does he more used to a print writing? So according to me, major issues would be in the areas of writing, not into the reading or the math. So I think my call on this is that's it.
Sure. Thank you. Yes, we have understood that academic functioning is pretty fine. Just before we wind up, I think there was a question from on the chat about to the autist, whether there are any checklists for teachers. Would the occupational therapist please like to respond to that? Uh,
Yeah. So
yeah.
as far as this particular child is concerned, the checklist would be primarily about his behavior in the class. So as we are aware of the ADHD checklist which we have, um, Vanderbilt scale can be used, and that can tell us about his conduct in the class. I do not seem, it does not look like a case of attention deficit or hyperactivity to me, but probably for the conduct part. So there are many checklists which we can use, but as far as this particular child is concerned, we would be more interested from the teacher about information that what is happening inside the classroom, what is happening between the classes, that is during the interval, etc. So that information would be needed for this child. And yes, there are many checklists available.
There's another question from Mr. Tony to Pooja ma'am. Along with the CAT test, you also mentioned HPT. Can you please elaborate on that?
Ma'am, is it for me?
Poonam, I think it's for Poonam,
Okay.
not Pooja.
It's not HBT, it's HTP. That's house tree person test. So maybe you might, might have heard that way, but it's HTP.
Yes. Okay.
It's
Thanks.
again a
Thanks for the
project.
clarification.
Yes, ma'am.
Thanks for the clarification. Yeah, Dr. Alka, would you have any thoughts about the case? Would you like to sum up in terms of interventions?
Thank you. Very well presented, Debosmita. And yes, very often we get these kind of cases where you have a congenital background. And I thought that it was very imperative that we do an MRI brain for this child, because there is something called as hypoxic ischemic damage which occurs to the brain, which is a non-specific damage which occurs at birth. And very often you see it in children who are along the congenital or neurodevelopmental spectrum. What happens with this is, because it's minimal brain damage, the volatility of the child, so their reaction to minor stimuli sort of gets exaggerated. And thereby, we find it difficult to gauge or to understand why this is happening. And that results in problems with peers, problems of conduct, problems with discipline, so on and so forth. In an otherwise seemingly okay child, or someone in this case who has splinter skills, where you're saying there's good IQ, there's ability to do so and so and so on and so forth. So we really need to keep that in context, that we may be dealing with a structural brain damage. And in order to combat that structural brain damage, the intensity of the occupational therapy, the physiotherapy, the cognitive retraining through special education has to be intensified. So we need to really have drill and practice to remodel the brain, use that neuroplasticity to change that trajectory. I hope that kind of fits in.
Yes,
yeah?
thank you.
Have a lot
Yes,
more.
it was. Yeah, thank you, Dr. Alka. Are there any questions? Yeah, I don't think there are. Since we are actually running late, we will go on to the panel discussion, which is basically a roundup of what we have had in the series. It's been very interesting. So I will hand over to Dr. Alka for the panel discussion, the power of collaboration, reflections on multidisciplinary teams and CAMH intervention. Dr. Alka?
Yes, thank you, Dr. Jyoti. And yes, we come to the end of our series, and it's been such a, what shall I say, enlightening and exciting endeavor to get this whole thing going. I think we started off with a lot of hesitation, wondering how we would be able to pull it off. But fortunately, the collaborative effort was so strong and so good that it got through. And point is very well taken, as Jyoti said in the beginning, that we will be including probably social workers and developmental pediatricians if this endeavor does go on, which I think has been quite useful for all of us. It's also very coincidental, and we are happy to see that this has fallen during Mental Health Week. So for logistic reasons, we couldn't have it in the end of September, but I thought that it's providence that we are ending it in Mental Health Week. So we started with a panel where everybody from the discipline sort of spoke about what their discipline does when you have a child who's coming to you in a multidisciplinary team. And then we went on to cases. And now we're going to wind up with a panel, because obviously we need to understand if whatever we are doing is in the right direction for the child, not for us alone, and would kind of give a completion to this whole exercise, at least for this period of time. So I'm going to request all the panelists to very quickly kindly introduce themselves before we go into the panel. The way that we'll be conducting this is that one question, all panelists answer. Second question, all panelists answer. Third question, all panelists answer. And then we open the forum for questions. Yes. So I'm Dr. Alka Subramaniam. I am a additional professor of psychiatry at Nair Hospital, and I've been there for 20 years now. I'll request, yeah, Jyoti, you want to go ahead next? So one after the other panelists, please introduce yourself, please.
Yeah, I'm Dr. Jyoti Shetty. I'm Professor and Head of the Department of Psychiatry, Bharati Vidyapeeth, University Medical College, Pune. And yes, it's been wonderful to be on this web series. Thank you.
Good morning, everybody. I'm Dr. Kaninika Ninavi. I work as a clinical psychologist at KEM Hospital, Mumbai, and I'm happy to be here.
Pratibha, you're muted. We need you to unmute.
I'm Dr. Pratibha Vaidya, Associate Professor and in charge OT School and Center TN Medical College. I've been there for almost 35 years. And I'm also the Vice President of All India Occupational Therapist Association.
Yes. Ms. Geeta, are you going? Julie, yes, please go ahead.
Good morning, everyone. I'm Zuili Khadakkar. I'm a physiotherapist working at Nair Hospital Early Intervention Center. I've been in pediatrics for 10 years now, and I'm also certified NDT therapist.
Good to have you here. Jyoti? Other Jyoti? Do we have Jyoti Mohiti has joined us? Okay, we can go on to Ms. Geeta Dalal. Yes.
Ma'am, my name is Geeta Dalal. I'm a clinical psychologist and special educator, and I'm really happy to be on this platform with all of you.
All right, so maybe someone can call Jyoti and see that she's joining us. While she joins us, let's just start off. And I'll go first to Dr. Jyoti Shetty and ask her, do you think the virtual MDT teams are going to be foreseeable in the near future? And if yes, then what are the limitations from a psychiatrist point of view?
Thank you very much for the question, Dr. Alka. I think when we started this program, it was actually because there was a felt need that a lot of the interventions teams are concentrated in tier 1, tier 2 cities, and not only is there a degree of ignorance, basically an inability to understand how to go about addressing these multiple handicaps or problems that a child faces and who to refer, and also about having specialized teams that could do the same. So our initial effort was actually to introduce this topic, that how a child can be viewed from different specialties and how the intervention could be done. And the web series was basically to understand how we could do that. But I think going ahead, what we have seen is that the teams not only work in terms of cases, but probably would also, going in the future, could probably help in giving expert advice, even probably training. We do have physiotherapists. I know from personal experience where my orthopedic surgeon has an app which helps us to have physiotherapy exercises. My physiotherapist does online therapy with me. So definitely, I do see a future in terms of, where we can have parental education. We can have even different specialists, especially psychiatrists who are in tier 3 cities, for example, having inputs in how to educate the patients that come to them, and having a multidisciplinary team set up where we can have something like telepsychiatry or therapies going on. So definitely I see it as a future. It's definitely cost effective also to some extent, to a large extent. So I do see a future for it. Limitations, of course, there would be limitations, because for me personally, I would always prefer at least one examination to be done offline, where it is on a one-to-one basis. There's nothing like actually seeing a child or seeing a patient and doing a hands-on examination, getting something, and a one-to-one at least once in 6 months or once in a year is something that's obviously required. The rest of the management could be done probably virtually. Yes, thank you.
Oh, thank you. Thank you for those inputs. Yeah, actually, the pandemic has really taught us, no, that the online world can be explored. I think that's where it all started. Kalimika, let's have your inputs on this.
I absolutely agree with both of you. I think the pandemic kind of exposed us to this space of going online and being available for people on and beyond the physical space of a hospital. And definitely, I see that the MDT virtual teams can make a huge difference going forward, especially like how Jyoti ma'am said, to the tier 2 and 3 cities where maybe the expertise is not locally available or scantily available. So definitely that is going to help them. There is also going to be a lot of rich exchange of ideas and learning, and therefore a better case understanding from all angles, and therefore better treatment for the client. So definitely this is a good idea. And of course, the limitation, as has already been discussed, is that certain assessments, clinical assessments, cannot be done completely fully online. And so we may not be able to come at like a diagnosis per se, like a proper diagnosis. So maybe ad hoc, we can do something and carry on. But at least once in a while, maybe, like physically meeting the client definitely makes a difference. So that way, that is a limitation, I feel. Otherwise, this is a boon. It is going to help people. Because there's no geographical boundary attached, and definitely there'll be a lot of help for the people in like regions that are not available.
True, true. All right, thank you. And then we have Dr. Pratibha.
Yeah.
Can you give us your inputs?
This virtual MDT teams actually will definitely add to the perspective of various practices. I think it will make the gap smaller and widening of the horizons for modes of treatment and outcomes. It will also provide a worldwide services, and of course it is always cost effective, and I think it is more flexible. Knowing various experiences of team members globally will also add to the authenticity of the services. But as an occupational therapist, to maintain high standards, it is essential for adopting the cultural specific ideas, which we see each of the child. And then the limitations which I can see is lack of interaction, maybe one, more personalized experience and humanistic touch. Also, sustainability in terms of collaboration may be a problem sometimes. And whatever we get virtually, that is transfer of virtual consensus to day-to-day practice may be a little difficult. So that is my view.
Yeah.
Yeah, very well rounded off. Thank you. And we have Zuili next from the physiotherapy group.
Yes, absolutely, I think that virtual MDT teams are going to work mainly due to the ease of accessibility to engage with professionals and have a holistic approach towards the management. As Pratibha madam said, it will also widen the horizon for cases from varied population, and it will not just limit to the institute-based education also for case discussions. Also, it will allow us to rope in experts from different sectors for their expertise conveniently. Uh, the limitations which I think can be taken care of could be technical issues or issues with usage of technology of adequate training. Uh, the main limitation from physical therapy point of view would be that we may have to rely on pre-obtained data and any assessment component that comes up during the discussions, say physical assessment or any specific test which is suggested by any professional, with that will not be feasible at that moment. So also privacy in case of virtual discussions or virtual assessments or virtual management, privacy of the client and consent from the client to be discussed, that can act as a limitation.
Okay, thank you. And I think Jyoti has joined us, Miss Jyoti Moite. Jyoti,
Yes.
please introduce yourself and then you can take the first question. Do you think that virtual teams are going to work? And if yes, then what are the limitations?
Okay. I'm Mrs. Jyoti Mohite, Associate Professor in Audiology and Speech Pathology Department of Nair Hospital. Yes, I feel from speech language pathology point of view, virtual.
Have your video on, or is it not?
It's on.
Please. No, we are not able to see you, Jyoti.
Okay. I don't know. Some issues there. Some issues there.
Okay, you continue, and we'll see in the next question. By then, maybe you can,
Okay. So I do feel this virtual team, MDT team, is the need of the hour, especially from an SLP point of view, when we are very few professionals available. So this is, I think, going to be the most important thing in near future. However, as everybody said, I agree to all those limitations, what they said. And additionally, from speech therapy point of view, there are certain therapy techniques which to demonstrate or to teach becomes little impossible. So we cannot do away with the one-on-one sessions also. Yeah, that is what I think.
Thank you. Thank you so much. And we have Ms. Geeta Dalal, special educator.
Ma'am, thank you for these questions. It definitely is going to be beneficial that the reach will be more, but for a multidisciplinary team success, it's fine. But individual work, if the special educator has to do academics, there may be success, but it would depend also on what is the difficulty of the child. Because if you're working on communication, of you're working with a hearing impaired child, then how will it work? Because devices will, again, whether it will be beneficial or not. If it is academic inputs, say spellings or comprehension or something like that, with the child with learning disorders or any other academic challenges, that should be fine. But if it is something to do with the ADL skills, which a lot of plenty of time the special educators have to do, take for example, even to teach brushing of the teeth. So at that time, there again would be a challenge. In 2-tier, 3-tier cities or in villages, they will reach out. That will be really good. But again, having two devices, one on where the child is working and which we can see, and we need to see the child also, the child need to see also. These are easily modifiable or addressable things, because if a parent is genuinely interested in taking the help, then they will definitely work on it. So reach wise, it will be good. A lot of work is being done online also now. And of course, the AI tools will also help a lot in this, in creating the worksheets, sending worksheets along with them, I mean, online, so that they do it. But for ADHD children, usage of screen, we would be increasing the time again. So that would again be a challenge. So I see pros and cons in both of these things. And definitely the pros are more because there are more professionals in cities and towns rather than, in some places like, children, like the other day, there was somebody from Balia, but to go up to Lucknow for work is very difficult. So then they've reached out to us for help. So that kind of a thing, that even if they have to travel 25, 30 miles, it's difficult for them. In Mumbai, we would travel 30 miles in any case. So lovely to have this connect that we can approach and reach more children.
Thank you. So from what I understand, all of you all are saying that virtual teams are absolutely essential in a resource-strapped country like ours. What we have managed to do with this endeavor is sort of on an all India platform, connect various people across, and we have viewership for those who are teams work. Of course, the limitation is examining the person or the child, right? And that seemed to resonate across everybody. So to take that forward, you see, we are shifting in terms of a society. Today, the mobile is not something which is a luxury. It is a necessity. We have converted our work to everything which is online. WhatsApp is an official medium of communication. Google Meet, Zoom Meets are ways that are part of our normal life and meeting. So too, AI, apps, and various endeavors which are converting everything that we do, whether it is exercise, whether it is recording of your ECG, whether it is assessment of a family, everything going online. Do you think, right, can actually convert into online? Is it possible for us to use this virtual space to convert therapy in an online mode? Will it work? Yes, let's start with the reverse. We'll start with Geeta first.
Ma'am, it will work, but dependent on condition to condition. Like I'm saying, with somebody with a speech disorder or...
Teachers are always diplomats. Really,
Yeah.
teachers are always diplomats. Yes, please go ahead.
What to do, ma'am? I also try. And also, I think the younger generation of professionals will definitely be much more comfortable. I mean, like at my age, I'm learning how to apply, how to take help of apps and Zoom. And, like you're saying, it's the order of the day. It's no longer a luxury, it's a necessity. But I mean, the older you get or the earlier you've been born, it is a challenge for that also. But it definitely is going to be beneficial, but completely online may not be a really successful thing. Of course, the brain is plastic, totally believe in growth mindset, neuroplasticity, changing, uh, the connections, the neural connections building with repetition. So maybe training the adult is easier in the house, and they can take up the daily work, which on a daily basis a special educator online may not be able to work. So I see it more as empowering the parent who is on the scene and that person. Because again, ma'am, how much ever we believe in neuroplasticity, it is the frequency of the matter which is being facilitated or taught, which has to be applied consistently. And online consistency with the professional special educator may not happen. So I see this more as empowering each parent. That can happen more online, and then they work more and we stay again wherever we are and guide more. I mean, we can see the child once in a while, we can, accordingly gauge progress, but physical progress or physical seeing the child, the entire body language, again, will not happen with that small screen where only the face is seen. So, I mean, I this is the way I see it.
Thank you. Thank you. Jyoti, Mohite. Yeah, we can see you now. We can, right.
Can you hear me now?
That's it. We can see you and hear you. Thank you.
Okay. Yeah. See, these are certain glitches that we can have with the online therapy, with the technical issues, definitely. But as far as I see, to give this, especially in therapy, what happens when we need to give tactile feedback for certain things, which is
Right.
absolutely not possible on the online platform. So what I see is like, where if a person comes to us on a physical or a onto one-to-one basis, we can teach that. But the maintenance part of it, as we said, when we empower parent, we can monitor that maintenance of the therapy is being taken or not. So this is what I feel, that complete shift to online is definitely a no-no for me.
Okay. Okay. Thank you. Thank you. Next, we have Julie.
Hello.
Yes.
Hello.
Please go ahead.
So we have seen the shift with online consultations and therapy sessions being the mainstay during COVID times. More than therapeutic strategies, I feel it is the informed involvement of parents under the therapist guidance which has positively impacted this shift. There are apps. If you go to consider apps, there are apps like MoveBuddy, Pure Physiotherapy, Pliability, or even children facilitated apps like Dexteria, Sensory Treat, which suggest specific activities and provides tool to monitor progress. These apps can be valuable extension to supplement the traditional sessions. However, it cannot replace the professional guidance. So I feel prioritizing individual needs and seeking professional guidance will always be the primary source of management. Having online guidance from authorized source can ensure follow-up in cases of patients staying far away or who face difficulties to get their children to rehab center. As ma'am had mentioned, it is cost effective, hence it will ensure continued follow-up in terms of monitored home program. It is also time convenient for parents to carry it out, and it is flexible. The parents are flexible to choose to work on an app or take online consultation, but it will definitely not replace the physical consultation what is required in at least first 2-3 sessions.
Yes, thank you. Pratibha?
Yeah. My basic thing will be, how about everybody having the access to this program? Like we are talking here, we began the multidisciplinary team collaboration by talking about giving access to villages or giving access to all the private practitioners, but everybody will not be able to have the technology with them to see what is happening. So this is a multidisciplinary approach. So there, generally the approach used is transdisciplinary, means so that one is trained and then they go and give the treatment to the unreachables. And the second point is the child who is, means mostly it is based on games, whether it is sensory, what Julie is saying. And these games do not have what you call feedback, social interaction, and self-expression. So the apps which are developed, if they have this technology along with whatever modalities they are giving, then it will be a good source, but not totally online.
Okay, thank you. Kaninika?
Yeah, I agree with most people here. And from a psychologist's point of view, I feel for the younger kids, especially with neurodivergence, intellectual disability, and ADHD, I think online treatment is very, very difficult because holding attention, we are using a lot of tools like art therapy, play therapy, that becomes very difficult to do online. Plus, we are trying to curtail screen use, which is also doesn't happen with the younger kids. A little older kids, 10 years and above, I think online work can be still implemented in a limited fashion. When it comes to assessments, IQ tests are very difficult to do online because we are, the whole spatial understanding of using blocks, etc., it's not possible. There are still some attempts at trying to validate some tools online. Like I know there is a Rorschach which now has an online adaptation that is being worked at, but not much fruit has come from it. So assessment wise also, it's going to be limited number of assessments that can be done, or we really need to adapt a lot of assessments to go online. Therapy wise, I feel that again, there's this new thing where, people are writing into the AI, and AI is kind of giving back statements from therapy. But I think it's just a chatbot at the end of the day, and there is a limited amount of resource that is available to an AI. I think as a person who's trained to do this work, most of us are going to be in a better position to look at what is coming up, understand the context, and then answer back from a lot of broad understanding of the area in terms of the theory as well as practice. So long-term therapy online definitely doesn't seem to be a very good option from where I see it. There are some apps, however, like Calm, etc., which can be used in terms of emotional difficulties of the client, where we, want to help them sleep better, or you want to relieve anxiety. Then they can just put on an app and follow the meditations or the JPMR or certain techniques like that. So that we can definitely use as an augment between therapy sessions. But I feel like physical therapy with the client and the therapist is still one of the best modes to go forward.
All right. Thank you, Kaninika. Dr. Jyoti Shetty, please, from the psychiatry team.
I would like to just make a difference. I think it was therapeutic strategies, app-based and versus and online mode. When we're looking at online therapies, I think when it is, for example, a psychiatric consultation, we do it online anyway. Now, since, as everyone said, since COVID, we have been doing it. Definitely, offline session is required. Online therapies, I think most of the psychologists I know, therapists do online therapy. So
Have we lost her?
Yeah.
Okay. Has she joined back, Swati? Okay, I think she had poor network.
Let me check, ma'am. I'll just check.
yeah,
Are you back?
yeah, I went offline. With all the panelists, I would just like to differentiate between, the online mode where therapies could be feasible, some form of therapies, not all of it. As everyone has said, there are certain therapies that need an offline interaction, much more minute detailing that is not obviously seen online. Barring that, with apps, I'm not really sure whether the extent to which apps can really help therapeutically. I think this is something that a lot of people have, in fact, Kanika spoke about, the chatbots and the limitations of that. So probably even physical therapy, for example, to some extent, it is all right. It is definitely cost effective, but I think we need an intervention by probably a physiotherapist to come in online to see how much of progress has been made, and an offline actually session to monitor it also. So it could be something that will reduce the expense in terms of contact periods, but probably offline sessions are not going to go out of vogue soon anyway. Thank you.
Yes, so what I'm understanding from what we have discussed is this has brought about two aspects. One is access to healthcare, where the online world really improves that. So you can connect with anybody, any specialist across the world. Today we're talking India, tomorrow this team could be international. Why stop ourselves? Yes. So you can access anybody you want across the world for a particular therapeutic input or an opinion, which is one thing, right? Which definitely the online world has given its great plus to. Number two is that all of us are in professions which are highly skill-based. human skill based. And today, the way we understand the online platform, the available apps, the AI and so forth, it's not replacing us. It's not replacing us simply because we still need that human interface. We still need that skill-based input, which is there. Kaninika very well summarized, I thought, by saying that all the mild disorders, and don't we see that even in the general population, that people who have mild disorders resort to yoga, they resort to meditation, they resort to, this is where the online digital world has really boomed, right? Has really boomed in a very big way. But those who have more severe disorders, and particularly children and adolescents, where you need more intervention. For example, therapies with adults still are taking place in the online world. Whether it is psychotherapy, physiotherapy, occupational therapy, education, those things are happening in the online world because it is possible to do so with adults who are largely self-regulating. With children, one is like Ms. Geeta said, we ourselves we are not digitally native. We are new learners in the digital world ourselves, right? And the opposite side is digitally native. So they are obviously much faster. In this webinar itself, we have had 2 technical glitches, which we have now learned to surmount. But once upon a time, when we had started off, we used to get pretty antsy about such things, right? So these are the limitations that are there. But I think that probably a hybrid combination of what is feasible online in therapy, or maybe follow-ups. So maybe 3 follow-ups online and the 4th one, I'm just talking aloud, it's not a protocol, but the 4th and 5th you will definitely see in person, so we can monitor progress and also intervene in a skill-based fashion. So that human skill and the human interface that everybody imparts as a therapist is certainly not going away. So maybe 10 years from now, things may change, and maybe we'll be having a discussion on that again. But as of today, the way we understand it, it's not going to be only online. All right. So which brings us to the final question for today. And I'll start with, again, Dr. Jyoti Shetty. Your one message that you want as a psychiatrist to give everybody, what is a take home from the learning of these MDT teams and in general, a multidisciplinary team functioning?
One take home that I would like, I mean, especially if there are young professionals here, is when we see a child and adolescent, we have to look at it from an emerge, and because of probably the paucity of available specialists, may not be able to refer, probably have access for referrals and having the the specialists available. But I would definitely say that we need to engage more with multidisciplinary teams for a holistic, more wholesome, and more productive outcome for interventions in child and adolescent mental health. So I think all the children, I think we deserve to probably learn much more about how the different disciplines treat and intervene, and hence be actually more sensitive and sensible for referring to appropriate specialities, rather than just looking at it from this perspective of, this is something that needs to be done, and from a psychiatric perspective, and leaving it there and then. It would be unfair for the children, the adolescents, and the families. And of course, it's much more productive as a society when we look at multiple teams intervening here. Thank you.
Thank you. Kaninika?
Yeah, I think much of the success of the MDT team relies on the fluent communication between professionals, including where they feel stuck in treating the patient. And there may be an overlap of choice of interventions used by 2 distinct professionals. If these MDT teams are to continue working with success, such interventions should be discussed by the professional whose primary work and training is in that intervention. So maintaining healthy professional boundaries based on the core competency of the profession will ensure healthy co-working experience for all the stakeholders.
All right. Thank you. Pratibha? You're muted. Please unmute.
I would say that we all are a part of a pond and have so much to share and so much to gain. But as a MDT team, each one has a different responsibility. So professional boundaries have to be maintained to be consequent and thereby referring a child as per the needs of a particular profession. That will be proper MDT approach. And one of the major goals would be converting this MDT approach, what series we are doing, to a sustainable program. It was a wonderful program where we are concerned about our own professional boundaries. Excellent. And I would say that this program, being we are working side by side in multidisciplinary approach. So this program has helped in building relationships and bonds between different professionals. It has also had, there was an appreciative, constructive feedback from each professionals. And it has led to an opening up of good collaborative communication. So we should continue with this. And I wish you all the best.
Thank you. Thank you. Really?
I feel a team is not a group of people working together, but a team is people who trust each other.
Yes.
Physiotherapist, we follow the ICF pattern, which suggests to look at all domains of health and functioning. Hence, we cannot just be focusing on physical components of a patient, and we need to take care of the sensory part. We need to take care of their mental health, their readiness to work at one point. And definitely it is not possible for us to just function without the help of knowing all these things. And to know all these things, it is better to have a good knowledge from experts of those fields. And hence this MDT exercise which is started is very effective and very vital for us to gain knowledge from different health sectors to optimize management better for our own client.
Thank you. Jyoti, Miss Jyoti Mohite.
Yeah. What I feel is, see, every person deserves a holistic management, and none of us can have knowledge of all the fields. So it is absolutely essential that we be aware of all the professionals and guide the person to the right person, whatever is required for that person. So MDT team is going to be really, really very important, and we should go ahead with this.
Thank you. Geeta? Miss Geeta?
You're muted, ma'am.
Yeah, just, you can hear me now?
Yes.
Yeah.
Yes.
Okay.
Yes, we
So
can hear you.
absolutely agree with everyone, because whenever a parent approach any one of the professionals, okay, the guidance to be given has to be the correct, and that has to be multidisciplinary, because no diverse condition in any child can be singularly, like Jyoti ma'am said also, that we can see the areas, the pockets which need help, but none of the professionals in any of the fields will have knowledge of everything. So the goal of many professionals who are involved in this, the goal is going to be the same. That's the improvement of the child. But the vision will change when we receive the perspectives from every professional. So a meeting between the professionals or an MDT team, the success of this MDT team itself, because our exposure is limited. Now, if I'm in a school, I have limited number of cases, I have a limited amount of exposure, and then expertise builds on a certain kind of diverse condition, and you still get lost in the broader perspective. But a learning of this platform, so this definitely should continue, ma'am. And like I was thinking, so much of creativity has flown in, there's so much of learning from each professional, and in the end of it, it is a leadership, ma'am. The way you all have created this bond and thing, there is a comfort level that we can sort of approach somebody for suggestions, we can take their help, and that is what is vital for the parents, because the parents really don't know where to go. They depend on the first professional to guide them that where should I go, and if we can give them that guidance, if we have the names of the professionals, the areas where the professionals are working, and whether they are willing to collaborate and work in a multidisciplinary approach, is extremely essential. And ma'am, this program, I know you said this is the last one this time, but I think this shouldn't stop. Whatever I can do to have it going, I'm ready to help for that.
What wonderful feedback. Thank you. So we're in, seventh heaven hearing all this, that you want this to continue, and we will definitely put it up to our central team. The reason we said that is because we are not sure if we are going to continue on this in this particular portfolio. But whoever continues, we will try and see that this endeavor continues, because it seems to have been taken well. And like Pratibha said, that what we have done is bringing together a lot of professionals under one roof, with respecting boundaries, at the same time connecting and building bonds. So as you can see, majority of us are dressed in orange today. So that's another kind of a bond, keeping the Navratri color in mind. And to have the quickest meetings ever, whenever there were admin meetings, as to how to go about with this, the platform and what to discuss for the next upcoming thing. And it was all very, very smooth, because I think it was just meant to be. When we talk of MDT teams in child and adolescent mental health, it is more of a norm rather than an exception. And I think the teams out here, including all the collaborative organizations, know that. You come into this space knowing that you are already collaborating out of this space. All we have done is translated that from a physical space to a virtual space, because at the end of the day, when you're dealing with children and adolescents, everyone feels the onus of responsibility that you're going to change the trajectory of a life.
Absolutely.
That same degree of empathy, I'm sorry to say, for an adult, because somewhere you feel that patterns in adulthood are largely already set and by themselves, and they can take care of themselves to a certain extent, which we don't find with children and adolescents. So there is that therapeutic difference, which, whether it is ethical, not morally right, wrong, that is a different debate. Let's not go into that, right? So we came into this space knowing full well that we have a singular mindset, and that is to make a difference in the life of this child and adolescent. And that we are going to continue. So one is whether we can continue this on a monthly endeavor. We definitely will try and continue. We'll get back to our central team, and irrespective of who's heading it, we'll try and see what we can do. Number two is, we have an app called as the Child and Adolescent Mental Health app, which was made by the IPS West Zone. Now, once we launched the app, we realized that there are some legal and permission formalities which had to be completed, which are now more or less done. It's in the beta testing has been done for psychiatrists. The plan 2, the phase 2, is to add all allied health professionals in it. So now we can do it in 2 ways. One is, once we get the permissions and we are set to roll, we will disseminate this for registration across all the organizations, so that you can include all your people on the platform. It's a very simple app. It's a referral app. So for example, if I am sitting in Mumbai and we have somebody in, say, Dhulia, right now we're restricting it to the West Zone, and I want to refer to Dhule, or they want to refer back to me, the occupational therapist, I just have to type in Dhule, or I have to type in the name, and I can send them across. And there will be a notification, an email notification, which comes to say that so-and-so is referred to you. So there's going to, of course, be a teething stage of 6 months to see if this is working. But I think this will really help connectivity. And we had kept allied health professionals out of it till now, because we were testing the app and we were testing waters, and we ran into certain logistic problems, which now has been surmounted. So this is definitely going to happen. The other way to launch it is, of course, we were talking about having a physical meeting where we would have this multidisciplinary approach, where we would present cases in person. So we also network in the human interface, and there too we can have it. So we could do both. right? So these are multiple options which are coming up and in the pipeline. Have a little bit of patience and they will work. I have to thank each and every single one of you for really being there with us and taking this right through. Really, it has been a wonderful learning experience, even for us in the West Zone. And I will request Dr. Jyoti Shetty, our chairman, to give a formal vote of thanks. But personally, from all of us, thank you very much. Jyoti?
Thank you. Thank you, Dr. Alka. This is just a formality. I hope our association continues. And as Dr. Alka said, onto the offline mode. I thank the IPS West Zone office bearers, Dhananjay, and EC coordinator, Dr. Hina Merchant, advisor, Dr. Alka, my colleagues, Dr. Mansi Somaya, who's our convener. I'm the chairperson of the Child and Adolescent Psychiatry subcommittee for this year. Our members, Dr. Swati and Dr. Nidhi Joshi. And of course, not to forget Yogendra, who's been giving us back office support on a Sunday. We kept insisting that we wanted to have it on a Sunday because everyone is available at this time. The poor thing had to take time out on his weekly off. And all the recordings are available on the IPS West Zone branch YouTube channel. So you all can all go back, and thank you all. I will like to mention the Psychologist Collective, the Indian Association of Physiotherapists, the Women's Physiotherapist Cell, Indian Association of the Speech Language Hearing Association, All India OT Association, the special educators, all the psychologists. I have been requested by a psychiatric social worker to include them in the MDT teams. Definitely, if we have something more, we will. The psychiatrists and everyone who has joined us here and continued and continue to give us so much of positive feedback. Thank you so much, and have a beautiful Navratri and happy Dasera in advance.
Thank you.
Same. Thank you.
Season's greetings. Enjoy the holidays. Thank you.
Thank you very much, everyone. It is just
Yeah,
wonderful
thank you.
experience.
Thank
you very
you
much.
so much.
Thank
Till
you.
we meet again.
Yeah.
Yes.
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 All right.
Yes.
Bye-bye.
Bye.
you.
Bye.
Thank you.